Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentaries on the JCO article assessing the impact of cooperative group trial on breast cancer care in Medicare population by Pamela R. Solis et al. My name is Thomas Buckles, and I am head of the Division of Radiation Oncology at the University of Texas MD Anderson Cancer Center in Houston, Texas. My oncology specialty is radiation oncology, and I focus my practice and research in breast cancer. Podcast title, How Cooperative Group Trials Impact Breast Cancer Care in the United States. It's a podcast on JCO 2011-394-890. Brief description of the podcast. In this podcast, I will review a JCO article showing that publication of CALGB C9343 trial results had little influence in practice patterns in the United States. I will discuss possible study-specific reasons for the lack of change of practice and explore the author's implication that practitioners are more apt to adopt trials that add technologies and/or treatments compared to those that withhold therapies. Solis and colleagues provide us with an interesting health services research article that investigated how the publication of a Phase 3 randomized trial investigating use versus omission of radiation after breast conservation therapy in elderly patients with favorable tumors failed to dramatically change the practice patterns in the United States. Their study specifically focused on CALGB C9343 trial, in which women 70 years or older who underwent lumpectomy with negative surgical margins for a T1N0 estrogen receptor positive breast cancer were randomized to receive whole breast radiation and adjuvant tamoxifen versus adjuvant tamoxifen alone. The results of this trial were first published in the New England Journal of Medicine in 2004 and reported very low rates of breast recurrences in both arms. Specifically, the 5-year breast recurrence rates were 4% without radiation and 1% with radiation. The authors concluded that because the rates were so low in both arms, that the use of radiation in this population was unnecessary. The updated results of this trial were presented by these authors in the 2010 ASCO meeting and continued to show relatively low rates of breast recurrence, 9% without radiation versus 2% with radiation. In 2005, the NCCN changed their breast cancer treatment guidelines to state that lumpectomy and tamoxifen without radiation was an appropriate treatment option for women 70 or older with stage 1 estrogen receptor positive disease receiving adjuvant hormonal therapy. In the current JCO article, Solis and colleagues used the SEER Medicare database to retrospectively explore how publication of the CALGB results changed practice patterns. Specifically, they investigated adjuvant radiation use in a sample of almost 13,000 women treated between the years of 2001 and 2007, and who fulfilled the CALGB C9343 inclusion criteria, namely being greater than 70 years old, who were treated with breast conservation therapy for a stage 1 breast cancer. The median age of their study population was 78 years old, and no data was available on margin status and hormonal therapy use, two important components of the eligibility criteria of the CALGB study. The results of their analysis were interesting. The publication of the trial had a very modest impact on practice patterns. Specifically, the use of radiation was 79% in the years prior to publication of the results, and in the years afterwards, this rate dropped to just 75%. They then looked at particular subsets of patients, such as those with shorter life expectancy. While the radiation use was lower in this cohort in both the pre- and post-publication time periods compared to healthier women, the absolute magnitude of the change remained the same, 4%. The change in the segment of patients with the highest life expectancy was similarly only 3%. I found this article to be interesting on many fronts. The authors are a high-quality health service research group, and the methodology and analysis of the study were well done. The CALGB study, however, included a diverse group of patients, and likely many practitioners in the United States based their treatment recommendations on the basis of competing risk of a patient and how their breast cancer ranks in their individual medical priority list. For a healthy 72-year-old marathon runner, my therapeutic goal would be to minimize the probability of breast recurrence over the next 10 to 20 years. In such patients, discussions about the use of radiation, I feel, are appropriate. In an 85-year-old with significant comorbidities, a favorable breast cancer would not be the most pressing medical condition, and clearly radiation would not be warranted. This was nicely quantified in a Journal of National Cancer Institute 2006 publication by Smith et al., which also used the SEER Medicare database and reproduced the 5-year results of the CALGB study. Because the sample size of SEER Medicare is much larger than that of the trial, they were able to specifically look at the radiation benefits in particular subsets and found that the number needed to treat with radiation to prevent one recurrence was only 21 in patients 70 to 79 years old with no comorbidity, whereas it was 61 to 125 for women over 80 with moderate to significant comorbidities, respectively. Finally, the CALGB study required all women to be treated with hormonal therapy for 5 years. Some elderly women choose not to receive hormonal therapy due to the associated side effects, and for such patients, radiation may yield higher absolute benefits than those reported in the CALGB trial. All this being said, I think there is likely some truth to the most interesting insight provided by the paper, namely the suggestion that medical providers, for a variety of reasons, are more likely to change when a new technology or treatment is added than when one is taken away. Removing treatments obviously benefits society by lowering national health care costs and puts individual practitioners' compensations at risk and are less attractive to patients seeking out high technology care. In contrast, new technologies and additional treatments add to the compensation and generate significant media and patient interest. Beyond the economics, all practitioners want to be part of rapid advances we are seeing in breast cancer treatments. For many, there is a psychological understanding that advances in treatment imply doing more. There is a greater discomfort about removing the standard component of therapy. An analogous breast cancer radiation example is the one analyzed in this JCO article, has been the relatively slow adoption of hypofractionated breast cancer radiation, which for appropriately selected patients reduces the overall course of radiation treatments from 5 weeks to just over 3. After publication of a phase 3 trial indicating equivalence, the shorter, less expensive treatment course was widely and rapidly adopted in Canada, but its dissemination within the United States was much more modest. It would be interesting to evaluate the rates of adoption of all practice-changing phase 3 trials results to test the hypothesis that trials that add treatments or technologies get adopted quicker than trials that decrease treatment cost. It would also be interesting to compare the rates of change in the United States versus Canada. This would more clearly test the hypothesis generated by the Solos paper. In summary, the Solos paper raised some interesting health care research hypotheses about the adoption of trial results. For an individual trial such as the CALGB one discussed in the paper, there may have been medically justifiable reasons for the slow adoptions of these results within the United States. However, their implication that there are also contributing economic reasons is an interesting conjecture, and one that can be tested by comparing these data to those from other trials and comparing how different healthcare systems adopt trial results. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.